All right, let's talk about degenerative bone disease. So, one of the examples of degenerative bone disease is osteoarthritis. I just wanted to clarify, I don't know why this picture is here. We're not talking about osteoporosis, we're talking about osteoarthritis. Anyhow, so osteoarthritis is the most common of all types of arthritis. It is the leading cause of pain and disability in elderly, and believe it or not, like I said in class, right, 90% of people has x-ray evidence of osteoarthritis by age of 40, and it can actually happen sooner. So again, this is often a result of a repetitive sort of activity that just causes repetitive damage to an area or joint that also ends up affecting the bones. So it can be localized or generalized depending on the reason or the activity level of the patient or the person. And how does it happen? So what happens is, again, from that repetitive trauma, it causes articular or cartilage loss or damage, and so the bone gets exposed. After that part of the remodeling process, as it's trying to heal itself, it develops a thickening in that area where that injury keeps on happening, and eventually it can lead to calcification, and which forms the bone spurs, and it can also develop inflammation. So that's really what causes the symptoms or pain or the difficulty with mobility. Risk factors for osteoarthritis includes increasing age, being female, genetics, trauma, again repetitive movements, being overweight, inactivity and overactivity, and then as well as hormonal imbalance. Cues or manifestations for osteoarthritis. So again, it involves the joints and it causes joint pain and stiffness. It can have some crepitus, so that crackling sound. And over time, right from that calcification, it causes the affected joints to be enlarged. So it can form like node-like deformities in the joint that's affected. So for the distal joint, we call it Heberdine's nodes, and for the enlargement of the proximal joint, we call it Bouchard's nodes. Again, so because it affects the joints, it can impair the range of motion and it can cause some flexion contracture. So basically, it causes the extremity or the body part to be flexed because of that calcification in that joint area. Now, make sure to differentiate it between OA and RA. And so RA is more of inflammation. We're going to talk about it later, but OA, it doesn't usually come with inflammation, especially this is a disease that happens over time. And so know that it is rare to see an inflamed, right, hot and inflamed joint in osteoarthritis. So how do we diagnose osteoarthritis? So osteoarthritis is diagnosed based on the history and physical, right? We need to know like what's the patient's activity level, when did it start, and so on. So basically information to help us determine, right, how did they end up with the joint issue. And so usually just from history, we can kind of have an idea of what is going on with a patient. In addition, right, X-ray can show us, kind of like this example over here, it can show us what's going on within the joint. So as you can see here, you can differentiate between the healthy or normal joint to an arthritic joint. So as you can see, there's some calcification. And so on a normal joint, you see that there should be some spacing here, but because of that repetitive trauma causing calcification, and so it does actually invade that area and it causes narrowing of the joint space. So that really leads to the patient's symptoms. On occasion, they may have to do a aspiration of the fluid within the joint to rule out other things such as gouty arthritis as well as septic arthritis or other conditions. So what do we do for patients with osteoarthritis? So we have conservative measures, so range of motion, just kind of making sure that we're moving, but it needs to be low impact. And then depending on what's going on with our patient, to treat the pain and sometimes inflammation, we can use ice or heat therapy. And medication-wise, we can give analgesics, topical, such as the ointment ointments to help with the pain. And then we can also have corticosteroids, so it can be more of a systemic, and sometimes it can be injected directly to the joints. And if the patient is having muscle spasms, which is quite common, especially in patients who have osteoarthritis in their spinal column, then we can give them muscle relaxants for the muscle spasms. Occasionally, right, if all the conservative measures are not helping and if the quality of life of the patient is being significantly affected, then that's when they start considering surgery. So the patients can have arthroscopy or arthroplasty. So arthroscopy is really a procedure where they use a long tube, thin tube to repair. So arthroscopy's intention is to repair the structure, and sometimes it also helps diagnose what's going on with the patient. On the other hand, arthroplasty is basically the replacement of the affected joint. So again, arthroscopy is used for diagnosis or fixing or of the affected joint. Meanwhile, arthroplasty is the replacement of the affected joint. So problem list for osteoarthritis includes impaired physical mobility related to pain and degenerative changes, can lead to self-care deficit, and it can lead to chronic pain related to muscle spasms and cartilage deterioration. Next, let's talk about rheumatoid arthritis. So going back to osteoarthritis, as I mentioned to you guys in class, oftentimes with osteoarthritis, it usually is affecting a unilateral joint. So usually it's only happening on one side. However, in rheumatoid arthritis, so this is more of a systemic disease, when it happens, it usually affects the bilateral or both sides of the body. So let's say it's the wrist, it usually will affect both of the wrists. Anyhow, going back, so what is rheumatoid arthritis? So this is an autoimmune inflammatory connective tissue disorders. Unfortunately, women are more likely to have rheumatoid arthritis, and it often starts as early as 20 to 40 years old. So that's the common onset of this condition. Now, the main cause, the definitive cause is actually unknown, but some studies show some genetic predispositions, some history of previous infection, as well as environment and hormones. So a really quick story on this. I mean, until now, I'm not really officially diagnosed, but years back, I started just having this joint pain. So it's bilateral. It usually affects my smaller joints, my feet, and my hands. And unfortunately for me, it was so hard to diagnose. They did all the labs, everything was negative, but the symptoms were similar to rheumatoid arthritis. So basically, I got diagnosed with some sort of rheumatoid arthritis that's seronegative. And I'll talk to you guys about it a little bit more, but just know that for this specific disorder, osteoarthritis is for older people, commonly older people, but rheumatoid arthritis, you can really get diagnosed at a really young age. And this is basically an autoimmune disorder. This is when your own body, when your own body is attacking itself. Anyway, this is a video that you guys can watch regarding rheumatoid arthritis. And please know, it's kind of like the osteoarthritis video that I talked to you guys in class. You can skip the first part where it's talking about the cellular level, what's going on with the tissue, like what chemicals and whatnot, right? For this specific course, you don't have to really know that. You can skip all the way to the signs and symptoms and common treatment. Hopefully that will help you. I mean, if you guys want to watch the whole thing, that's fine too. But hopefully that will help you understand rheumatoid arthritis a little bit better, or RA. As I mentioned to you guys earlier, so RA is an autoimmune disease. So this is when you form autoantibodies. So this is when antibodies are attacking your own healthy tissue. So inflammation happens in the synovial membrane, and then it can spread to the articular cartilage, the joint capsule, ligaments, and tendons, especially if it's not being treated, right? The inflammation keeps on going, and it's really one of these kind of like negative like cycle that keeps on happening. The more damage it's causing, the more inflammation it's going to have, and then that inflammation is going to cause more damage. So it's just a continuous cycle. And so the synovium thickens and it creates pannus. So pannus is really that area, that broken down, thickened cartilage. Manifestations or cues for RA. So it can include fatigue, loss of appetite, low-grade fever, muscle and joint aches, stiffness, and then multiple joints inflamed in a symmetrical pattern. So that's key, right? It's symmetrical. And because of inflammation, the joints may appear red, swollen, painful, and tender. So again, remember this has, because it's a systemic disorder, it's an autoimmune, a systemic autoimmune disorder, you will have systemic symptoms. So it can affect the whole body, hence having the fatigue, loss of appetite, and so on. Some of these patients may have Sjogren's syndrome, which is basically dryness in their eyes and mouth. They can have pleuritis, so inflammation of the pleura or the lining of the lungs. They may end up with pericarditis or inflammation of the lining of the heart. They can end up with anemia, which is the specific type of anemia is anemia of chronic illness, and then vasculitis. As you can see, it can affect the whole body, right? The system as a whole. So it's not just focused on the joints, although that's the common and manifestation and common complaint is the joint pain. And then eventually, especially if it's not being treated, if it's out of control, it can have a lot of systemic manifestations. So how do we diagnose RA? So first we need to get a history and physical, right? When does the pain happen? How do you feel? Any family history and so on, any recent illness. And so definitely get a thorough history of the patient and then labs. So usually if they're suspecting some sort of autoimmune disorder, right? If there's no other possible reason of their symptoms, they may start trying to rule out autoimmune disease or RA. And so labs include RF or rheumatoid factor. So it is found in 80% of the patients with RA, and they also ordered ANA. So ANA, one thing that you have to know, although patients with RA may be positive for ANA, you may also have a negative ANA, and not because you have a positive ANA that you automatically have RA. We also can see orders for ESR or erythrocyte sedimentation rate or CRP. And those are just inflammatory marker. And as mentioned to you guys with the other conditions, that can be elevated because of any other type of inflammation. So not because they're high that the patient have RA. So it's not very specific to rheumatoid arthritis. CBC can be done, right? Because we want to rule out what's causing the other symptoms, right? Especially the fatigue. And so sometimes anemia alone can cause fatigue and they don't necessarily have RA. So we look at the CBC as well. CCP, which is your cyclic citrullinated peptide. This is another marker of RA. And then another thing that they may do is the examination of the synovial fluid, similar to what they do for gout, right? So they want to aspirate the fluid and see what's in there. Obviously, if there's uric acid, then it may be gout. If there's some signs of infection, then it may be a septic arthritis. And so they just want to pull whatever fluid is in the joint to kind of rule out other conditions. Other diagnostics include joint x-rays. It shows some erosion of the joints, and usually that's in late RA. And in bone scan, it can show some inflammation in the joint area. And sometimes x-rays are not enough. They may order some CT scan or MRI just to see if there's any inflammation that may not have been detected on the x-rays. So rheumatoid arthritis or RA management. So how do we manage this type of condition? How do we care for this patient? One of our priorities, not that it's number one, right? It just depends on what's going on with the patient, but one of our priorities is to relieve the pain. Again, this tends to be chronic. So once they have this diagnosis, these patients end up with chronic pain. So we need to make sure that their pain is under control because having chronic pain can actually affect the quality of their life and their health, right? And so one way to do that is other than giving pain medication is also to reduce the inflammation because most likely the reason for those symptoms is because of that inflammation. Also resting and exercising. So we just have to time it correctly. There is a moment to rest and there's also a moment where they can actually exercise. So just finding that balance. And then plasmapheresis is another intervention. So plasmapheresis is really a process wherein they remove the plasma and they try to clean out those inflammatory cytokines or immune complexes to hopefully help alleviate the overly reactive immune system. So that's the way to help kind of regulate the immune response of the patient. And we also have some other alternative treatments. It's not mentioned here, but it's also very important to have the patient evaluate and kind of have a diary of things that could be triggering the worsening of their symptoms. So for me, as an example, is I notice that if I eat really unhealthy food, if I eat a lot of processed food or food that's really high in carbohydrates or sugar, it tends to make my joint pains worse. So finding those things and really cleaning up your diet can also help with the symptoms. I know it's not included here, but know that those things can actually make a difference. Medication wise, knowing that it is a problem with inflammation, not a structural problem, right? Then we can give medications that help with inflammation. So NSAIDs, right, non-steroidal anti-inflammatory drugs would be one of the first medications that we will use for these patients. Compared to the other medications, these have less side effects, so this is really first line for them, and then see if it works. Sometimes if it doesn't work, we can use it in combination with other drugs. Another one is your corticosteroids. So corticosteroids, so because this is a systemic disorder, right, unlike the osteoarthritis, we can inject it directly to the joint, right? Because usually it's local. Unlike that, in rheumatoid arthritis, if we're going to give them steroids, it needs to be systemic treatment. And the most common way of doing that is through oral corticosteroids. Knowing that, please remember your GHATs, side effects of steroids, because if you're going to give it to a patient with RA, you may want to know what the side effects are, right? We also give them anti-rheumatic drugs or immunosuppressants. So know that anti-rheumatic drugs or immunosuppressants, they do have a lot of side effects. So many doctors don't really start the patients on them right away because again, because they're immunosuppressants, what's going to happen to the patient's immune system, right? Other than the severe side effects, they are at more risk of developing infections or sepsis. So that's one thing to think about before, giving this medication to these patients. On occasions, it's not as common. On occasions, some patients may benefit from local injection of corticosteroids. Now, as I mentioned earlier, it's not as beneficial for this type of patients because let's say most of their joints have some issues with inflammation, right? Injecting it on each joint is not the best way to address the inflammation. Really, you want to give them systemic treatment. But unfortunately, when you're giving systemic treatment through oral corticosteroids, then you may run into the systemic side effects. So again, risk versus benefits, and that's why we usually start with NSAIDs. And if that doesn't work, we can start giving corticosteroids or a combination of. And then last resort will be your anti-rheumatic or immunosuppressant drugs. So problem lists for RA include impaired physical mobility, ineffective role performance, especially from the chronic pain. And it's really sad, you guys, patients who have autoimmune disease, it does affect their day-to-day, especially most of this autoimmune disease starts at a younger age. And so it affects how they interact with their loved ones. It affects their hobbies, their ability to work, their ability to think. And so yeah, so just keep that in mind, especially with, again, with these patients with autoimmune disorders or chronic disorders. And sometimes it can cause disturbed body image, right? Because it affects any joint really. And then chronic pain as well as fatigue. Next, we're going to talk about infectious disorder, mainly osteomyelitis. I kind of mentioned it earlier in class that sometimes the infection can spread in the bone. So it can lead to osteomyelitis. Osteomyelitis is infection in the bone. So it can be caused by fungus, parasites, virus, bacteria, and it's most commonly seen in the legs, feet, pelvis, and spine. The most common reason for spine osteomyelitis is from a decubitus ulcer. So I see that a lot in the hospital. Now, it can be osteomyelitis can be acute or chronic. So know the difference, right? So acute it's less than 6 weeks. Chronic is lasting more than 6 weeks. So it's just a difference in duration. So what happens here? So what happens in osteomyelitis is that the bacteria gets lodged in the bone and they start to multiply. That's what they like, right? That's what they do. So as long as you give them enough nutrients, a little bit of blood supply, right? It's warm, it's moist, then they start multiplying. So it can lead to phagocytosis and of your white blood cells, because your body's going to try to fight it, right? You can have some pus in that area, and some inflammation can occur in that area, causing the periosteum to lift. And it can, because of that inflammation and the tissue damage, it can lead to ischemia and necrosis. So etiology of osteomyelitis. So there has to be a source of infection, right? So again, it can start from an infection. It can be from a penetrating wound. So it can be a direct contamination of the bone. Sometimes, again, if we have a patient who had a recent fracture and maybe we didn't do a good job cleaning doing the pin care um, for the fixation, it can be from a gunshot wound, maybe from a compound fracture. It can also be from a surgical complication, so including prosthesis, so maybe they didn't handle it well, and also a complication from neurosurgery, so maybe a spine surgery that didn't end up going well. Now, it can also originate from an adjacent tissue. So like I told you guys, a common reason for an osteomyelitis of the spine and coccyx area is from the cubitus ulcer. It can also be from a UTI or an infected tooth. So from the infected tooth, you can have osteomyelitis of the jaw bone. At times, it can also be associated with vascular insufficiency, so problem with the vascular system. So you see that in patients who have diabetes and peripheral vascular disease. So they are the ones who are the higher risk. In addition, patients with diabetes and PVD tend to have some neuropathy. So what happens if they're not able to feel any injury, right? They may not be aware that they have a wound. So it exposes the foot to trauma and pressure ulcers without them realizing it. And then again, it can start an infection and leading to the spread of the infection all the way to the bone. Manifestation of osteomyelitis can include low-grade fever or malaise, so just generalized feeling of not being well, cardiovascular effects. So think about this in addition to the musculoskeletal symptoms. Think about this as similar to an infection or sepsis, right? So you may have fever, malaise, tachycardia. Sometimes some patients may have some nausea, vomiting, anorexia, weight loss, and again, depending on the part of the body that's affected, they can be limping, and sometimes they may have some localized tenderness in that extremity. And integumentary wise, skin wise, you may see some drainage, ulceration, swelling in that area, erythema, and warmth, right? So warmth is going to be an indication of infection. So really, signs and symptoms of infection. So diagnosis of osteomyelitis. So in diagnosing osteomyelitis, we can use bone scans. It scans the bones just to see, right, what's going on there, and it can show the area where there's osteomyelitis. We can have MRI and CT scan. X-rays tend to not be enough. So you may have a patient who had an X-ray, and there's really, to be honest, it's really hard to see if somebody has osteomyelitis on an X-ray. So what they do, even after an X-ray, they may order a CT scan or an MRI because it does show a little bit more of the softer tissue. It shows inflammation, and it gives a clearer picture of the presence or absence of osteomyelitis. And then biopsy can be done. So this is, again, kind of typical biopsy. With a needle, they try to remove part of the tissue and send it for biopsy. And that's how they're going to be able to identify the presence of infection in that bone tissue. Blood tests can be ordered, and so they may order CRP and ESR. So ESR is erythrocyte sedimentation rate. CRP is C-reactive protein. And so again, these are inflammatory markers, but sometimes they're just high for any type of inflammation. So it doesn't really specify the cause, right? So even if you have an elevated ESR and CRP, so let's say you just bump your knee and it caused some inflammation, it can make your ESR or CRP elevated. Other things can cause ESR and CRP to be elevated, so that's not as reliable. The main thing is you want to look at the biopsy and the scans. CBC can be ordered. So on a CBC, you may see an elevation of WBC. And although generally speaking, WBC is up in presence of an infection, you may have some patients who are immunocompromised whose WBC may be within normal, or if the infection has been going on for such a long time, right? At one point, your body's going to have a hard time trying to keep up with the demand. So you may even see a decrease in WBC in severe infections. And at times we may have blood cultures ordered. And because the main reason is because osteomyelitis signs and symptoms are very similar to your sepsis signs and symptoms. So you want to rule out sepsis, and at the same time, know that if we don't take care of osteomyelitis, it can lead to sepsis, right? And so you may see some blood cultures ordered in patients with osteomyelitis. So osteomyelitis, how do we manage osteomyelitis? Mainly it's IV antibiotics. I never really worked in an outpatient setting. So generally speaking, when patients have osteomyelitis, they need IV antibiotics. In addition to that, obviously pain is going to be an issue. So pain management with some analgesics. And then depending on what's going on, especially if they're having a hard time treating the infection, they may have to do surgery or debride the area. So this is really removing those that dead tissue, that infected area, to hopefully allow it to heal better. When it comes to debridement, just be cognizant that because it's an invasive procedure, although it is used to help heal osteomyelitis, it can also make it worse. So it's really a matter of weighing risk versus benefits of doing the surgery, and it's a case-by-case basis. But if they are running the risk for losing a limb, they may actually rather do the surgery, right, the debridement, rather than losing the limb, right? And so things to consider when caring for these patients, and things to kind of reinforce when it comes to giving them patient education. All right, osteomyelitis problem list. So one thing is risk for complication leading to sepsis. So if we don't intervene, if we allow osteomyelitis to continue without treatment or without proper treatment, it can lead to sepsis. So again, there's a risk for infection. The infection can spread to the neighboring tissue. Hyperthermia is a given, right? It can increase your temperature secondary to the infection, impaired physical mobility, and patients can have acute pain. But my main concern, what I'm really worried about, is for this infection, right, to not get better and to cause sepsis down the road. So going back, nursing interventions, we really need to get our patients' history and physical, any past medical history, any history of PVD, diabetes, or how long have they been having those symptoms, any increase in temperature at home, any fever, any recent medical condition. Had they had a recent infection, such as a UTI? Did they have a recent invasive procedure, such as a surgery? Any oral issues? Had they been complaining of toothache? So anything pertinent to how the patient presented, right? So you want to get a thorough history and physical from your patient. And then assessment. So assessment, you may want to look at your vital signs, right? So those are going to be cues. It's going to give you cues if the patient has any infection, any nausea, vomiting. Have you looked at the labs, right? WBC, ESR, CRP, any localized tenderness, pain in the area, any swelling, ulceration, drainage. So basically, you're assessing for signs and symptoms of infection, either systemic or local, right? Because as I mentioned earlier, osteomyelitis symptoms are very similar to your sepsis symptoms, but with exception to with osteomyelitis, you have some more localized symptoms pertaining to the affected extremity or part of the body. Now, administration of antibiotics and analgesics are part of your interventions, and we may need to collaborate with the wound care nurse, right? We may need to collaborate with the physician depending on what's going on with your patient. And so wound care nurse, maybe to help with addressing changes, especially if there's no order for it. And also you can collaborate with a dietitian or nutrition nutritionist to kind of help with the nutrition of the patient to facilitate the wound healing. You may want to collaborate with the surgeon. Maybe it needs more debridement. Maybe you want to report any changes that's going on in that area. And then teaching the patient. Teaching the patient is very important, especially even before going home, but especially if you know that they're going home, they need to be able to care for that site because as you may have noticed, not because they still have the infection that they're going to end up staying in the hospital. So sometimes we just stabilize them enough, right, so that they don't need hospitalization, and they may send them with home antibiotics or maybe antibiotics through home health. But these patients need to know, right, the signs and symptoms of infection. What are the things that they need to keep an eye on? What are the things to report? When should they go back to the doctor? How should they take those antibiotics? And really hand hygiene. How should they care for that area? And hygiene in general, right? Environment, what should they be eating, and so on. So there's a lot of teaching involved because again, at the end of the day, most of these patients, especially here in town, even though they're not really 100% well yet, they end up being discharged home. So that's very important. Patient education is very important. All right, NCLEX questions. A client has a total knee replacement and a CPM device is being used. The nurse understands that teaching was effective when the client's ID identified the goal of treatment as A. Maintain muscle tone, B. Improve flexion of the joint, C. Prevent tissue breakdown, D. Avoid formation of thrombus. Before we answer that question, we need to know what a CPM device is. CPM device is a continuous passive movement device. So this is kind of like one of those devices that they connect and the patient maybe can have like, they just moves their extremity, right, to allow for range of motion. Anyhow, so the main goal, so the answer to that would be B, improve flexion of the joint. And again, mobility is key, especially after surgery, because if you keep it still, that's what you don't want to do, right? You're going to lose that. It's going to be so stiff if you don't start moving those extremities, regardless of the pain. So again, I told you guys, that's why it's very important to treat the patient's pain so they can do these exercises or activities. Next, a client is in skeletal traction while awaiting surgery for repair of a fractured femur. The client's complaining of leg discomfort and asks the nurse to release the traction. Which is the nurse's best initial response? A, I will remove half the weight and notify your physician. B, I'll get your pain med to help relieve your discomfort. C, I can't do that because the weights are needed to keep your bones in alignment. D, I have to follow the physician's directions and releasing the weight is not ordered. So this is a little tricky, right? And so read the questions carefully. So looking at this, right? A, I will remove half the weight and notify your physician. We shouldn't do that, right? It could displace the fracture. It can actually make the situation worse. Now, the answer is actually B, right? I'll get your pain med to help relieve your discomfort. And so again, the patient is just complaining of pain, and the main reason why they're asking for them to release the traction is because of the pain. So if we address that, then hopefully the patient is going to feel more comfortable and they will not, continue to complain about the traction. C, I can't do that because the weights are needed to keep your bones in alignment. It's not completely incorrect, but it's really disregarding the patient's complaint of discomfort. Same thing with D, right? I have to follow the physician's directions and releasing the weight is not ordered. So this C and D are kind of similar. If you think about it that way, they're not necessarily incorrect, but it's not addressing the patient's concern, right? If we just tell them that and they're still going to continue to be in pain, they're going to continue to ask you to take it off, or they may start taking it off themselves, right? Because they're in so much pain. So we need to address their pain. So that's why the answer is B. The nurse administers allopurinol to a client with gout. The nurse explains that the goal of this therapy is to A, increase bone density, B, decrease synovial swelling, C, decrease uric acid production, D, prevent crystallization of uric acid. The answer to this is C, it decreases uric acid production. Which medication should the nurse anticipate being prescribed to relieve the pain experienced by a client with RA? A. Xanax 0.5 milligrams PO/TID, PRN pain. B. Ibuprofen 400 milligrams PO every 4 hours, PRN moderate pain. C. Codeine 30 milligrams PO every 4 hours, PRN. D. Meperidine 30 milligrams PO every 4 hours, PRN for pain. So as you can see here, I mean, it's really hard to really prioritize the question, right? Because sometimes it all sounds correct. But here you have a patient with RA. Think about RA, right? It's an inflammatory disease. So in order to really address the issue, right, you have to address the inflammation. And the only treatment that addresses the inflammation here is your ibuprofen, which is an NSAID. So the answer here is B. Ibuprofen 400 milligrams PO every 4 hours, PRN for pain. All right, that's it. Thank you so much. I'll see you guys next week.